I guess. We are just with the pancreatic cyst section of the road. You are putting a bit under the sun on camera. So, so I worked as a biologist persistent disease in the head. But I've seen most brands of such animals so just to say, decide if the patient has work temperatures and which foods, where's the system, about what I'll do, that I think together with the person who failed
Thanks, everyone.
the Ottawa Hospital, and he is a general surgeon and assistant professor there. He has completed medical school and residency at McGill. in Montreal before he pursued fellowship in had a biliary surgery at Seattle's Big Sun Medical Center as a HIV surgeon who is primarily interested in the surgical treatment of diseases of the liver, pancreas, and biliary food, and has a special interest in laparoscopic and minimally invasive techniques. His research focuses on surgical outcomes and the use of big data to address and inform questions surgical patients, specifically as undergo surgery of the liver, pancreas, and biliary.
Okay. I don't know what classification of pancreatic cysts. We're all pancreas surgeons here. We know what these categories are. But essentially, the goal of imaging here is to help us categorize and correctly diagnose, and then eventually to surveil these. And so, a perfect imaging modality would be an imaging modality that can confirm the cystic nature of a lesion, as well as describing the morphology of the cystic lesion. Is it microcystic, oligocystic, macrocystic? Demonstrates communication with the pancreatic duct, shows us classifications and their pattern, demonstrates the presence of true mural nodules and differentiate them from just a mucin ball, allows us fluid analysis and tissue sampling, be reproducible and independent of operator, safe and tolerable, and inexpensive. And of course, no single modality has all these characteristics. And so we are going to have to pick and choose, and together we're going to kind of fill out this matrix together. We're very familiar with CT scans as surgeons, and they have very good spatial resolutions, especially with thin cut CTs in the pancreas protocol, facilitates surgical planning, gives you staging as well if the malignancy is already established or is highly suspected. You can get a good idea of enhancement characteristics. And if you have a very large nodule, and by large, we'll go over that evidence in a moment, but something over 2 centimeters is pretty much just as good as an MRI in the US. Characterize the morphology of the cystic lesion. I'll show you an example of that in a moment. You have difficulty identifying septations, small mural nodules, debris, particularly with advanced communications. And of course, it's got ionizing radiation, limiting its use in long-term surveillance. This is an example of how a CT scan performs. This is classic, microcystic, cystic neoplasm. You can see some punctual calcifications in a central scar. But, I'd be lying to you if I could tell you that I could see the anatomy of these cysts very well. You can, however, see that circumvascular sign that is quite characteristic of cystic neoplasms. Compared to the image that you are going to see for a classic cystic neoplasm MRI, where you can clearly see that honeycomb microcystic structure. So just highlighting the strength of the MRI here in terms of the anatomy of that cystic lesion. MRIs and CT scans actually have similar accuracy to characterize pancreatic cystic entities. In the case presentation earlier, you saw that report said this is a CT scan, probably an IPMN. You should get an MRI to confirm that. And they probably would have both agreed that this is statistically likely a side branch IPMN. And so accuracy is actually low using single modalities, and very often you need more than one modality to combine, because oftentimes you might have some conflicting information. And that's very different from the recommendation for staging. This is the European guideline that says that for surveillance, you should rely heavily on an MRI rather than a CT scan, except in very specific circumstances. Assessment of classification is important, and if a malignancy is already suspected, to help with staging and operative planning. And so, when it comes to identifying malignancy that's associated with a cyst, a CT scan actually performs just as well as an MRI. This is from a systematic review and analysis of multiple trials in this field. That's when a malignancy is already there. If it's a slam dunk malignancy, CT scan is going to be just as good as an MRI. For the cysts surveillance, it's going to be slightly different. MRI is very good at ductal communication identification, mural nodules and their enhancement, up to a certain size, as we'll see in a moment. It's a costly test, and patient experience leaves something to be desired. I'm sure we've all prescribed our fair share of benzodiazepines for all patients having MRIs. This is kind of what a nodule looks like. MRCP image, you see this filling defect within this side branch IPMN that's communicating with the pancreatic duct. See on the arterial enhancing, which there's actually no arterial enhancement in it. This is just a mucin ball, and you can see that confirmed on the endoscopic ultrasound there. This is a just to illustrate the point. This filling defect here actually does enhance, and so this is a true nodule. Further an MRI compare with an endoscopic ultrasound detecting neural nodules. You can see here a neural nodule that is shown just as well on both the EUS and the MRI. And for this, there are multiple other studies, but I'll just point to this series because I think it just illustrates the point the best. Large nodules, over 2 centimeters. A CT scan, and even percutaneous ultrasound, if you have the right body have this is a Japanese series, or an endoscopic ultrasound, they're all just as good. But the smaller that nodule is, ultrasound actually starts to shine. So that we start to understand why things fit the way they are in Fukuoka. For smaller cysts, you can use a CT or an MRI, pretty much however you want, and some patient preference. One thing that we go to MRI alternating with EUS, and EUS really takes center stage point for those cysts where you really want to know if there's a nodule that is starting to sprout there, because a CT scan is not going to give you that idea, that is not going to give you the information, and an MRI is also unlikely to give you that information for a very small nodule. So let's talk a little bit about EUS and its modern iterations. More than just in the US, there are now contrast-enhanced EUS, which can improve the sensitivity and specificity in detecting the presence of true neural nodules and distinguishing them from mucin balls. And there's a lot of wizardry now associated with the EUS. There's microforceps biopsy or through the needle biopsy with a small microforceps, as well as EUS needle confocal laser endomicroscopy, which is not entirely ready for prime time, but it is something that is kind of on the horizon. And that's kind of what that looks like. They basically introduce a laser microscope through the needle of the EUS, and they basically look at the cyst content inside. So it's this nice mix of EUS with microscopy, and based on the different patterns, you can differentiate the kind of cystic entity that it is. So cystic neoplasms allegedly have this very characteristic vascular pattern. In IPMN, you're going to see papillary projections. In using a cystic neoplasm, you're allegedly supposed to be seeing this very clean endothelial lining. And too much about transabdominal ultrasound. There's a lot of studies that shows that it is just as good as EUS if you have the right body habitus, which can be quite challenging in our populations. Adiposity and overlying gas, and it's probably better to appreciate cysts in the head and parts of the body than it is to see something around the splenic hilum. But in selected patients, it could be used for surveillance. It's inexpensive, it's well tolerated, and it's cheap. So these caveats that are stated around the whole time. So this is kind of what that summary slide looks like. Each one of these modalities has its pros, its cons, along some of the characteristics that we talked about. So although CT, MRI, and EUS are equivalent in their accuracy at diagnosing a pancreatic cystic entity kind of in general, combining more than one modality improves accuracy. CT and MRI are equivalent in detecting malignancy, once you have a full-blown cancer that's already established. EUS excels at detecting small enhancing nodules. MRI is favored for surveillance, although CT is acceptable for low-risk tumors in Fukuoka guidelines. Again, there's ionizing radiation there, so you got to take that into account. And there are some emerging technologies at the intersection of endoscopy, EUS, and microscopy that could improve diagnostic accuracy. Thank you.
Yeah, due to time, we're going to defer the discussion about imaging. And next is Dr. Montes from Mass General to discuss the molecular analysis.
Okay, thank you so much for that. I appreciate the opportunity to be here today. So I'm going to talk about molecular analysis of pancreatic cyst fluid Of course, as we all know here, the audience needs no introduction to this, but there are a variety of histologies when it comes to pancreatic cysts, and it's important to understand that not everything we look at is IPMN, even though it is called IPMN. There are actually a lot of potential differential diagnoses for these cysts. But the important thing is we know that potentially in some data, about 50% of over 70-year-olds could have pancreatic cysts incidentally detected on imaging. And really, the overarching objective of what we try to do when we analyze these cysts is, number one, to identify the type of cyst, and then number two, to identify at least the chance of advanced neoplasia. Of course, if it were easy just to resect all of these cysts, we would, but pancreatic surgery carries an inherent morbidity and even mortality. So we have to be selective. Now, in terms of the need at doing better, we know that that is the case, and we do need to do better. We actually looked at this in our institution over a 3-decade period. We looked at 1,290 pancreatic cyst resections at MGH, and this was published recently in Annals of Surgery. What you can see is, the good news at least, is there has been an increase in the concordance between the preoperative diagnosis and the final pathologic diagnosis that actually improved by decade. However, 20% of cases still had an incorrect diagnosis, and 10% actually had a benign diagnosis that was mostly serous cystadenoma. So we definitely do need to do better. And currently, what we do know is that the IPMN epithelium evolves via dysplasia to invasive carcinoma sequence via low grade to high grade. But we also know that the most accurate feature right now that we still have for detecting high-risk IPMN is a dilated pancreatic duct. So far, the greatest reliance that we have in the US cyst fluid analysis has been on CEA and cytology. If you actually look at what we consider our go-to guidelines, at least at our institution, are the IAP guidelines. And in fact, if you try and look at molecular cyst analysis, it's actually that last row. There's really not very much on it in the IAP, and that's from the iteration from 2017. And we're waiting the most current iteration to come out and see how much more there will be in there. But just to be clear, there are currently 3 avenues in practice that we use at trying to understand and define these IPMNs a little bit better. The first one is the clinical radiologic and endoscopic features, plus or minus the cytology. And the two that I'm going to focus on today are the cyst protein biomarkers and the DNA-based fluid biomarkers. So the first one we just heard a lot about, and is basically the Fukuoka guidelines, as you know. We're moving on, looking at cyst protein biomarkers. So these include things like CEA, amylase, CA19-9, glucose, and by the way, there are many others. Just delving into a couple of those in a bit more detail. So CEA, a prospective study originally by Bill Brady and colleagues, and using a cutoff of 192, we were 80% accurate for mucinous cysts. And of course, with any of these biomarkers, increasing the cutoff increases the specificity, but decreases the sensitivity. And a low CEA, of course, therefore does not exclude mucinous cysts. Now, this may be up for some debate at this point, but typically CEA levels do not predict malignancy within mucinous cysts. So in terms of CEA, identifying the type of cyst, sensitivity and specificity, you can see listed here. And in terms of identifying high-grade dysplasia and invasive carcinoma, the numbers actually drop a little bit. Amylase, this is one that we sometimes discuss in our own tumor boards that we would do away with. But basically, it's very useful at picking up pseudocysts, and values less than 250 would rule out a pseudocyst. Then it gets a little bit messy here, as you can see for IPMN and MCM. Low values may be consistent with those, but high values are non-specific and can be included as well. And we're typically low in serous cystadenoma. But again, in detecting pseudocysts, probably the best thing is still a good history in physical in terms of trying to figure out a history of pancreatitis. Some of the other protein biomarkers here, so you can see CA19-9, and you can see quickly here the specificity and sensitivity drops quite a bit for this as well. And again, utility tends to be a little bit more limited. In one manuscript that I reviewed, I saw that glucose was called the upcoming champion. And there are actually potential benefits from including glucose that we're now starting to do at our institution. And less than 50 appears to be highly sensitive for mucinous lesions. There are debates about the different cutoffs that can be used, and again, dropping to 10 may increase the specificity even more, helpful when combined with CEA. But of course, there are multiple ways to measure glucose, and there could be a lot of variability in that. But you can see here the sensitivity of 93% and specificity of 76% from some pooled data that I found at less than 50. So this is a really nice study that was done by Kaylin McIntyre that I've seen around, and Peter Allen, looking at protein cyst biomarkers. in addition to clinical mammograms that they had. And it's actually a prospective evaluation of 2 clinical and molecular models in patients with unknown pathology. And it combines what they had before, a clinical radiographic mammogram, to 2 cyst fluid protein micromodels that they incorporated, including, you can see here the protein CA72-4 and MMP9, and then in the second one, SFOSL and IL-4. And the treatment decisions were based on unusual conventional clinical decision making. They had 26 resected patients that had low-grade IPMN and 9 had high-grade IPMN. And when we use the clinical mammogram alone, only 2 of 9 patients would meet criteria for being predicted as high risk. But when they added the molecular models to that, 6 of 9 in each of those models were considered high risk. So adding the cyst protein biomarkers did actually increase the ability to predict high risk lesions. And then onto DNA-based biomarkers. So you can see here there's a whole sort of battery of these, and there's actually a lot more as well. But going through probably some of the most important ones here. So KRAS, GNAS are probably some of the ones that people in the audience are most familiar with. KRAS mutations are most commonly seen in mucinous lesions. GNAS present in IPMNs and would specifically help distinguish from MCNs, since these don't tend to be present in MCNs. In terms of identifying the type of cyst, these are some of the pooled sensitivities and specificities that I found out there. But you can see here, what's good about KRAS, GNAS, and the combinations is they're very specific. So when they are present, they are very specific for mucinous cysts. They're not very sensitive, so they don't always have to be there. However, they're not good at detecting high-grade dysplasia and invasive carcinoma, so that's not what we use them for. So this is just purely to identify the type of cyst. Then when you start to introduce these particular ones, CDKN2A, PIK3CA, SMAD4, and TP53, you very quickly see that they are really good at, very specific at identifying the type of cyst. However, and this is probably where the field is sort of beginning to change now, is that they're actually also very specific at detecting high-grade dysplasia and invasive carcinoma. So when you do see these present, those do alert you to high-risk lesions. MEC5AC or LUC5AC is turning out to be a very important marker as well, potentially a DNA-based biomarker. You can see here both to identify the type of cyst and to identify high-grade dysplasia and invasive carcinoma. And just a quick mention about VHL, highly specific for serous cystadenoma. So if you see that, that typically will represent a serous cystadenoma. So there are now some platforms and some commercial platforms as well. Pancreatic is one of those important ones that are actually proprietary to UPMC. And you can see here in terms of the data that it spits out, basically will tell you about the type of cyst, but also the risk of high-grade dysplasia or invasive carcinoma. Of course, this is an important study by a good friend, Alessandro Paniccia. It's actually a great study, a prospective multi-institutional study. And the aim of this was a large prospective study to evaluate the role of next-generation sequencing in a multi-institutional study in real time. This was a 22-gene NGS panel at 31 institutions over 2 years. Remarkably, 98% of specimens were adequate for testing. So compare that to the acellular mucin cytology reports that we see. And 66% of those patients had a follow-up, median follow-up of 23 months. And based on 251 patients with surgical pathology, the authors were able to show us that MAPK and GNAS had a 90% sensitivity and 100% specificity for predicting mucinous lesions. However, when you combine again with some of these markers that we've just seen, TP53, SMAD4, CTNNB1, and mTOR, there's an 88% sensitivity and a 98% specificity for predicting advanced neoplasia. Again, this is where the field is beginning to change here. The inclusion of cytopathology improved those numbers. You can immediately realize here is that these data are far superior to the AGA and IAP and other guidelines that we've had so far that are clinical based. The authors were able to show a couple of additional findings, including VH1 and MEN1 loss of heterozygosity alterations that were actually specific, particularly specific for serous cystadenomas and also for pancreatic neuroendocrine tumors. Importantly and impressively, none of the 965 patients that are identified in that study over that median follow-up period developed malignancy. So what they were able to conclude is that Pancreatic is highly sensitive and specific for both diagnosis of cyst type and advanced neoplasia. And I'll just put this table up here so that you can see, I hope that you can see that the sensitivities and specificities of these DNA-based biomarkers are far superior to anything you can see at the bottom of the screen that traditionally came from IAP guidelines and such. There are other platforms. Dr. Winslow just mentioned Pancreatic as well. Same idea, same concept, slightly different gene panel. And this is the type of report that you get, including the alert to high risk. So finishing up, this is my conclusion slide, but the diagnosis of cyst type and probability of malignancy is best served, I think, with all of these things, including combined history, physical endoscopy, cytology, protein biomarkers, and DNA-based biomarkers. And you can see now that the sensitivity and specificity and the accuracy data that we're seeing from the DNA-based biomarkers are superior to anything else that we've had so far. KRAS and GNAS are especially good at identifying the type of cyst, but the ones that we mentioned so far, CDKN2A, SMAD4, in particular, seem to be coming across different panels for advanced neuroplasia. And again, I think this is just a call that, of course, management of these cysts in specialized centers with pancreatic cyst clinics and conferences and the ability to grow biobanks. Thank you for your attention today.
Thank you. Our discussant of this paper, of this presentation is Dr. Helena Facundo. Thank you. Like to remind that to combine dimensions and faced with an epidemic exist. She was assigned to a management option, and by the exception of a minority that identifying as issues, will undergo long treatments Next presenting guideline updates, Dr. Ryan Young. Ultrasound evaluation. Last time they did surgery, it's This paper. So to discuss a little bit about open guidelines. Sure. I was if you want to discuss because to show functions and groups are symptoms symptoms about those guidelines on one way because Sixty% of choose So it's important to go see as there was also Thank you. That was very efficient panel. So we left ourselves 5 minutes and we have taken questions or comments from the group. I have a question to the speaker. Guidelines. So
Go for some biomarkers that seem to be highly specific for advanced neoplasia. I mean, I think ultimately that's the biggest thing that we need to. I remember that
Discussion, great presentation. I'd like to thank everyone. Mohan Kutlu from the University of Miami. I was going to go home, but I just was waiting. MCNs, IPMNs, we have the Venus guidelines for those, and it's an area of interpretation. However, as you know, HPV Twitter is a thing, and there's this entity that we were all discussing what to do about, which is serous cystadenomas. Like, what do you do with those? Like, you have a 6 centimeter cystadenoma body tail of the pancreas versus a 6 centimeter cystadenoma head of the pancreas. What do we do with those? Like, are they going to get bigger, wait, observe, operate? Because we know that the potential is extremely low, and we have to justify an operation not to hurt the patient. Thank you.
That's a very interesting thread with a lot of varied opinions. So, ultimately, we have to really talk to the patient about the true risk, as far as we know, of carcinoma. Then we have to figure out if there's really any symptom coming in and what the downside for that patient would be. So even though I have this visceral reaction to this should not happen, we have a patient whose whole brain is filled with serous cystoma and there's a cancer in the head. I don't know exactly what I'm going to do. I'm just about to leave this patient, but there's no obvious step. I'm not sure what would happen at the transaction. So, anyway, others, serous cystoma.
I think it's a tough one. So, like the first thing I want to say, like symptomatic versus asymptomatic. If it's symptomatic, your discussion's basically going to go towards surgery. But if it's asymptomatic, which is probably what you're asking about, and I don't think you're really wrong. There are numbers that are floated out in terms of anything bigger than, but honestly, I mean, it's hard to know. I think you have to take into consideration the age of the patient, the fitness of the patient, the growth rate, if you can establish that over a series of a couple of scans. And if the patient's young, for example, and it's growing rapidly, you probably do want to take it out before it becomes problematic and becomes unresectable. So I think it's a multifactorial sort of decision, and then involves a huge conversation with the patient. And I always say, I think these conversations need to happen over time with patients that I think Cystic can as well. There's always the benefit of time especially with something like serous cystadenoma.
Yeah, I'd agree with that. I would also say, mutation analysis can sometimes help. This is fluid content. Very often if these patients have a P53 mutations and it correlates with the growth rate, and that might help you make a decision in this regard. You have a 8-10 centimeter cystic neoplasm, and they do have a P53 mutation in it. It doesn't correlate with risk of malignancy or anything, but it does correlate with growth rate. On the other hand, I've also seen 70, 80, 90 months with SCNs, the size of a watermelon, and they feel totally fine. And so, I would say even for patients who are symptomatic or maybe symptomatic, I think we have a very candid discussion about what living after a Whipple also feels like, and that's very well real. So in general, I tend to steer patients away from operating with an SCN. And someone once told me, I think it was also one of those Twitter wisdom things. Someone said that the leading cause of mortality from serous cystic neoplasm is surgeons. It's a resection, and no one dies from an SCN. I don't think I've ever heard of anyone dying from an SCN.
Next question.
Yeah, thanks. Thanks for the nice discussion. My name is Sri Kavatra. I'm from Michigan State. So my question, I have a patient who has pancreatic adenocarcinoma in the head of the pancreas, and he also has a 1.2 centimeter dilatation of the main duct all the way up to the tail of the pancreas. And we got a cyst fluid analysis. CE is about 4,000 from the cyst, the duct itself. So in the 77-year-old, he got neoadjuvant chemotherapy. So now he has to do a surgery. So what surgery would you do on this patient? Just a Whipple, total pancreatectomy? What would you do?
Take a vote. I personally would vote for the transaction at the neck and know how good this protocol I would have in place to tell. There's a couple of different reasons. One is the diagnosis is probably largely driven by the cancer. The other is, but there's just a quality of life issue for patients who don't live very long and have true risk, which you can manage if you need to.
So you think like high glucose ratio on the frozen section?
Probably put that on this is very controversial, but I think in the end, you can task if you're looking at that, see if there's any fire regions, some violence, but make a decision on surgery, how aggressive you will be. I personally have older patient who had a known abnormal, I would try to get the patient. I look to what that's and then
Especially suspicious within that entire pancreatic gland that looks like neuromodularity or something like that. First, and if there was cancer confirmed at the time of frozen, I would stop because I think that's going to be the life-limiting problem, not the rest of the gland. So that's the only additional.
You're not within the distal duct.
Yeah, I think a lot hinges on, I would make sure that I have a very clear discussion with the endoscopist doing the EUS, saying we're looking for nodules and describe every single nodule, see where are the most of the papillary projections and target that. I think it's very important.
If the patient has any service strategy, if the remainder of the service other than the ductal dilatation, but if it's 77 about because we're told that I think there is some component that I know that
That's good.